My name's John Boehmer. I'm from Hershey, Pennsylvania. I'm the other business in Hershey, not the one that makes the chocolate. Penn State College of Medicine is there, and that's where I work. And I'm going to talk about something I've been working with Boston Scientific for in excess of a decade now, and that's a way to diagnose heart failure and then lead to the management of heart failure. And it's a algorithm called HeartLogic that gives you an idea of the risk of having heart failure events, and is going to lead to treatment of heart failure events. So I'm going to introduce it, but first, why would anyone ever want to monitor people with heart failure? Why not just send them out, let them do their thing, and then see what happens? Well, the goal is really to identify heart failure in an early stage when corrective treatment is simple. When the patient shows up in the emergency room and they're gasping for air, game over. That patient's going to be admitted to the hospital. Similarly, when they come into the office, they're 20, 30 pounds volume overloaded, they're edematous, they got a swollen belly, their renal function may not be quite what it was. It's hard to manage them at that point and catch up and get rid of that excess fluid. However, if there's just a small shift in fluid and you can apply corrective treatment at that stage, it's much, much simpler. You want to provide feedback to the clinician to allow fewer routine visits for the patients with stable heart failure and more needed visits when the probability of worsening heart failure is high. So we do transitional care from hospital to home, much like everybody's doing these days. And what our nurses do is they manage everybody. Everybody's being discharged gets pretty much the same protocol of getting phone calls, visits, home health, what have you, in order to try to prevent the next episode of heart failure. But wouldn't it be better if we figured out who is at risk and who is not at risk, and then applied those resources to those at the highest risk? And you'd like to provide feedback to the patient to encourage healthy choices like, maybe that cheesesteak was a bad idea. Diabetics get this all the time. They eat a high carbohydrate meal, they check their blood sugar's high, they apply insulin, and they correct it. We don't have the glucometer for heart failure yet, at least not quite in that form. And then we want to be able to treat worsening heart failure when it occurs. So what we came up with was an idea to develop an alert algorithm for the early notification of worsening heart failure by combining information from a diverse set of implanted sensors chosen to target different aspects of heart failure pathophysiology associated with common signs and symptoms of worsening heart failure. We looked at heart sounds, thoracic impedance, which has actually been out there for a while, and some people think it has a good signal. We do too, but we don't know if it's enough by itself. Respirations, activity, and heart rate. So I'm going to show you a couple cases early on, because oftentimes we put the cases at the end of this discussion, and sometimes we're rushing through the cases at the end, and this is the most fun, and it feels the most clinical. So this is our patient who had a HeartLogic alert threshold crossing right here. This is the HeartLogic index, and then these are the various sensors we can monitor with this system. This is the third heart sound. We actually can pick up the third heart sound with an implantable defibrillator by using the accelerometer that's in that defibrillator to pick up vibrations. Technically, it's not sound, it's vibrations, it's measured in milligauges, but those vibrations can look like a heart sound, and you can pick up a third heart sound. You can pick up a first heart sound as well, and it turns out when people have worsening heart failure, in general, the first heart sound tends to decrease. Thoracic impedance is shown here, respiratory rate. So we can measure thoracic impedance, and you may be familiar with this technology. It's been in defibrillators for in excess of a decade. And it's measuring the resistance to electrical flow between a lead in the heart and the defibrillator on the chest wall. In between there's some lung. When the lungs become wet, the electrolyte solution of the fluid is a good conductor, so the resistance to electrical flow goes down, the impedance goes down, and you can measure that. Similarly, when the lungs are dry, air is a poor conductor, and the impedance goes up. But you can also follow this over a respiratory phase. So when somebody takes a deep breath in, that impedance will go up. When they breathe out, the impedance will go down. And you can measure the respiratory rate very precisely, and this is a daily average of respiratory rate. Nighttime heart rate, weight scales are still hooked up in this system, as well as weights. And the accelerometer in the defibrillator can also monitor activity, much like a Fitbit or Apple Watch can monitor your activity with an accelerometer. So, at time point 1, the patient crossed their HeartLogic threshold, and it was driven mainly by an elevation of the third heart sound, as well as an increase in respiratory rate and nighttime heart rate. Then at time point 2, the patient was seen in clinic at this time. Worsening heart failure symptoms were noted, and the patient was then started on Entresto. We hadn't been receiving the information on this particular patient. They hadn't plugged in their communicator at home, and that was plugged in at this point. And then the patient was followed closely on the remote system, Latitude, and by time point 3, there was a significant weight reduction. And what we saw was that the third heart sound at least leveled off. The first heart sound stabilized, and the respiratory rate started to come down. Nighttime heart rate stabilized and started to come down. And the HeartLogic index eventually started coming down on that patient. Here's another case just to show you how this is all going to work. Again, the same thing, HeartLogic index, third and first heart sound, thoracic impedance, respiratory rate, nighttime heart rate, activity, mean heart rate, and heart rate variability. And this patient exceeded the HeartLogic alert at time point 1. At this point, the communicator was not plugged in. This was driven again by mainly third heart sounds and first heart sounds, as well as a rise in nighttime heart rate, which is a risk factor for worsening heart failure. The communicator was then plugged in, the alert was sent, the nurse called him. He wasn't taking his medications as prescribed. His Entresto was increased and started on spironolactone. And at time point 3, things were improving. The third heart sound got quieter, first heart sound leveled off, thoracic impedance rose, heart rate came down, and he went out of HeartLogic alert at that time point. Just one final one here to show you one more case of how this is working in the real world. This patient was discharged from the hospital with heart failure symptoms and unremitting abdominal pain. And at time point 1, he's just about to go into a HeartLogic alert, and you can see that there's a rise in third heart sound, first heart sound not changing, thoracic impedance may be dropping. Respiratory rate took a big jump up, nighttime heart rate took a big jump up, and it was all of the metrics in this particular patient that was leading to the HeartLogic alert that occurred here. The patient did show up in the emergency room, shortness of breath, difficulty sleeping, vague abdominal pain. He was planning to be discharged from the emergency room, but the sensors were noticed. He was admitted and significant fluid was removed. He actually had a stent placed for coronary disease, what was diagnosed. So let me talk about the study in which we developed this algorithm. It was called the MultiSense trial. In this study, sensor data and clinical events were recorded in 900 patients followed for approximately 1 year who had symptomatic heart failure in the past 6 months. The way we did this was to take a market-release defibrillator and upload its software to be able to collect high-fidelity sensor data from the market-release device. So we changed a market-release device into a research device via software. The data were divided into a development set of 500 patients to develop the algorithm, and another 400 patients were then sequestered to validate the algorithm once it was established. I think it's going to get close to that. Heart failure events were independently, Heart failure events were independently classified by a clinical events committee, and heart failure admission and unscheduled administration of IV diuretics or ultrafiltration was what was defined as a heart failure event. So primarily heart failure hospitalization, and clinicians and the clinical events committees were blinded to the HeartLogic index data and all the sensor data within the study. And this is the primary endpoint of this study in order to validate what we had. These are the data from the validation cohort, not the development cohort. The development cohort actually looked better. And what you have is sensitivity on the y-axis and a measure of specificity on the x-axis. So this is a modified receiver operator curve. The measure of specificity we used was the number of unexplained alerts we received per patient year. So if you get an alert that doesn't lead to a heart failure hospitalization, that would count against you on this one. So the less specific it is, the further out in this direction you go. But we didn't call it a false positive because in many cases it really may have been heart failure. It just wasn't enough to lead to a hospitalization. We don't have a perfect endpoint to define what worsening heart failure is. And what we found with the validation data set was that we calculated indexes anywhere from 6 to 44 threshold, but we chose 16 from the development set because that was pretty much in the middle of the receiver operator curve, and we wanted to test that one. And we wanted to be two endpoints. One was we wanted a sensitivity in excess of 40%. Actually, we wanted it to be statistically significantly greater than 40%, which means numerically it would be greater than 50%. And indeed, we had a sensitivity of 70% that was highly statistically significantly greater than 40. And we wanted a specificity of less than 2 unexplained alerts per patient year. And we came in at 1.47 unexplained alerts per patient year. And importantly, the alert first preceded the event a median of 34 days prior to the event. So time from alert to heart failure hospitalization or other event that defined in the protocol was 34 days at median. So it has quite a long lead time from alert to event. And this is data I really like from the trial. So we divided the population into two groups. One group, shown here in blue, that had a heart failure event, and the other group, shown in black, that did not have a heart failure event. We normalized the time frame from the group with a heart failure event, with time 0 being when they were admitted to the hospital. And then we went back 6 months, 180 days worth of data. And the group that didn't have it, we normalized their data in comparison to the group that did. So what you see is the group that had a heart failure event at 6 months prior already had a higher HeartLogic alert than the group that did not. And it continued to rise leading up to the heart failure hospitalization and was statistically significantly greater than that 29 days prior to the event, significantly greater than their baseline. But throughout the whole thing, it was greater than the group that did not. So what does it mean when a patient goes into HeartLogic alert? How much risk are they at when that occurs? And we tried to show that with a calculation called the event rate ratio. The way we did this was we took the number of events that happened when patients were in alert, divided by the number of days they were in alert, and then took the number of events out of alert and divided by the number of days out of alert, and then made a ratio of those two. In other words, what's the risk when in versus what's the risk when out? We did a similar calculation for NT-proBNP that was drawn at baseline. This is the result for the HeartLogic index for a variety of thresholds. This is from 10 to 40. The nominal threshold is 16, although it's programmable for other ones. Less sensitive but more specific at lower numbers, more sensitive but less specific at higher numbers. But no matter where you are on this, no matter which threshold you choose, it's tenfold greater when in alert than not alert at the nominal threshold of 16. In alert, 0.8 events per patient year. Out of alert, 0.08 events per patient year. And it's between 8 and 12.5 for the rest of the thresholds that are here. Importantly, only 17% of patient days are spent in alert. So it's only a small group of patients that are in alert at any given time. And the event rate ratio, again, range between 8.4 and 12.6. These are the data for NT-proBNP through a variety of cutoffs for NT-proBNP. In the literature, many people use a cutoff of around 1,000 for high risk versus low risk, but it doesn't matter quite where you go. NT-proBNP performed well. Generally speaking, the risk of a heart failure event in patients who had a high baseline NT-proBNP was 3 to 4-fold higher than those with a low NT-proBNP. And this is a very good predictor, very well accepted in the heart failure community, particularly for its prognostic ability. But you can see that through all these various thresholds, the HeartLogic index performed much better than a baseline NT-proBNP. And what's also is important, I mentioned to you that only 17% of patients have a HeartLogic index over 16 at any given time. And you can see at higher thresholds for HeartLogic, that percentage goes down. At lower ones, it goes up, but it only goes up as high as 25%. Whereas for 1,000, for an NT-proBNP threshold, 40% of this population at baseline had an NT-proBNP over 1,000. So if you want to identify a small high-risk population, this will get you down to only 17% of patients to worry about. This, you have to worry about 40% of patients. So defines a much smaller population to worry about. Are these data really kind of the same thing with just different abilities? No, they're not the same thing at all, actually. And this is a demonstration of this. So the two bars on the left are the patients who had a low NT-proBNP. The two bars on the right are a high NT-proBNP. Within these two, out of HeartLogic alert and in HeartLogic alert. And this is the rate of heart failure hospitalization. So for the lowest risk group that had a low NT-proBNP at baseline and was not in HeartLogic alert, the event rate was 0.02 events per patient year. Whereas the highest risk group with a high NT-proBNP and in HeartLogic alert, the risk was 1.0 events per patient year, or a 50-fold difference between the high risk and the low risk group. Well, if you think we're just cherry picking though, 50% of the population was in this low risk group and 10% of the population is in the high risk group. If you want the next highest risk group, it's those that had a low NT-proBNP but were in HeartLogic alert. They had a 23.5-fold increase in events compared to the lowest risk group, and that's another 70%. The next lowest risk group is not in HeartLogic alert with a high NT-proBNP. They had a higher risk, but it was still relatively low compared to the higher risk groups who were in HeartLogic alert. So you can combine these two if you want to get better refinement. They're not quite the same thing, but they do behave well together. And then importantly, we're going to be embarking on a large clinical trial. We are in phase 1 right now, the MANAGE-HF study, which is a multi-phase study that aims to evaluate the clinical integration and utilization of the HeartLogic diagnostic feature and its impact on heart failure hospitalization and patient mortality in patients implanted with a CRT-D or ICD device. In phase 1, everybody has the HeartLogic device, and the clinicians are able to see the data in everyone, and we're just studying how well we do in terms of treating it, time from alert to treatment and how that treatment works in terms of reversing the sensors. So we're looking for about 200 participants in this phase. And then we're going to move on to phase 2, which is going to be an event-driven trial with 1,500 to 2,500 subjects. And the endpoint is going to be a morbidity and mortality endpoint in a randomized clinical trial. In that trial, everybody will also have a HeartLogic-enabled device. However, the investigators are only going to be able to see data in the intervention group. The control group, we will not see the sensor data. And we're going to see if managing the HeartLogic events is going to lead to better outcomes for that population. So I also get to, I guess, show these slides that give you a lot of the legal description of what's going on with this device, because it is a market-approved device now. For a long time, I didn't have to worry about this because there was nothing on the market. But with that, I'll entertain your questions. Anybody have any questions about what we're doing with this device or how we're managing heart failure with it? Yeah. That's a fantastic. How often do we check the HeartLogic alert? So I told you the median time from alert to the event is 34 days. And 89% of the events that occurred happened at least 2 weeks after the alert. So if an alert occurs on a Saturday, you don't deal with it on Saturday, you don't deal with it on Sunday. You can deal with it on Monday. If Monday's busy, Tuesday's okay. If Tuesday gets out of hand, Wednesday's okay. Sometime during that week, you want to deal with it. And what you want to do is evaluate the data, maybe contact the patient, put it together with your clinical sense, and then decide what you want to do. In general, you know that this patient's at high risk. And I would argue, and certainly what we're doing in the MANAGE-HF trial, is treating, much like you would for a weight gain. And I think this is much better than a weight gain in terms of predicting the risk of heart failure. So you're going to treat. You may escalate their heart failure therapy, as the examples I showed you with Entresto. You may give diuretics, but you're going to do something to try to make the heart failure condition better. If you're giving diuretics, you're probably going to want to monitor that with some safety and follow up with electrolytes and renal function. And then once you've done that, don't look at the data for 3 days. In fact, if you don't want to look at the data until next week, that's okay too. No sooner than 3 days, no later than a week, and look at the data again. You want to make sure that whatever intervention you made is making changes, at least in the individual sensors. Now, in the multi-sense trial, the investigators and the clinicians didn't have any of the data. So we didn't treat the data. But in that trial, the median duration of an alert was, I think the median was 30 days and the average was 38 days. So they can be in alert for a long time. And it's actually designed to go into alert and to drop the threshold then, so it takes a while to go out of alert. By doing so, it doesn't flicker on and off. Have you ever worked with other systems like maybe CardioMEMS? And their PAD is up one day and then it's down the next and then it's up the next again? This doesn't do that, okay? This goes into alert and it takes its time. It's more like a ship at sea. It's got to kind of turn slowly and then go back the other way. But as long as things are going okay and things are trending in the right direction, you're okay, and then look at the data again the next week until your patient's out of alert. It may take a few weeks for them to go out of alert. That's typical. So, yeah.
How easy is it to implement this into a heart failure clinic? And maybe
Yeah.
some of the pushback you've gotten from staff, nurses.
We don't have that.
Yeah.
I have a couple of my nurses here. But that's a great question. So how do you implement this in terms of the workflow? Well, what we're finding is generally electrophysiologists put in devices, and they may put this in a patient who seems appropriate, who may be a high-risk patient for heart failure, and he may or may not be built into your particular patient clientele. And then what happens when the alert occurs? And what we've been doing is we've been reviewing the alerts, myself and our nurses, contacting the doc and communicating to them and educating them about what the system is and what the risk of an alert means, and then encouraging them to treat and giving a suggestion of treatment. The treatment algorithm in the MANAGE-HF is, the short answer is double the diuretics for 1 to 3 days. That's the short answer. It's a little more detailed than that, but that's the short answer. So increase the diuretics for a period of time, or escalate their therapy, such as Entresto, if that's appropriate. So treat them and then follow the sensors. But you have to work with whoever the primary clinician is treating them. And we have found, I think in general, when we offer to help them treat, the docs are like, oh, thank you. Yeah, you got that same experience? Yeah, so if you're going to give them the diuretics and check the BNP, then they're usually grateful that somebody's doing this and it's not them. So that's how we implement it. There's also the issue of where the data goes, because device clinics, the data goes to the device clinics, and our data still does go to the device clinic, but we created a separate group within the software so that the HeartLogic data is accessible to our heart failure nurses, and they're getting the alerts and they're managing it, and that's the way that's working.